Okay, good afternoon, everyone. We're going to get started as we're a bit behind on schedule. So I want to start by thanking Jonathan Spicer and Normand Blais for inviting me to moderate this session about new concepts in early-stage lung cancer. So I'm Marie-Hélène Deneau. I'm a respirologist at IUCPQ in Quebec City, and I'm joined by Dr. Cools, who's a thoracic surgeon at McGill University Health Center. First up is Dr. Henning Willers, radiation oncologist and clinician scientist at Mass Gen in Boston, talking to us about how to create synergy between radiation and systemic treatment.
All right, thank you very much. That was nice music. I hope everybody is asleep now. So one important question that occurred to me is how many radiation oncologists are in the room? One? One. All right, friendly crowd. Fantastic. All right, let's get going. All right, so thank you to the organizers for inviting me. I'm not sure I should thank you for the topic, new concepts to create synergy between radiation and systemic therapy. I wish I knew, but I'll try my best. Also, not thank you for putting me in this position where I have to give this talk after Dr. Salma Jabbour already gave it twice yesterday. So I'm trying to do my best to cover some new ground here. So bear with me. I have no conflicts. And these are the learning objectives to tell you a little bit about what radiation does, that it is immune stimulatory and it's also suppressive, and how do we create synergy from that. So what is SBRT? As you already know and may have learned, there are lots of different ways to do this, technically speaking. It all does the same thing. It ablates the tumor with generally very little side effects, but there could be quite important differences in how we deliver radiation and how that affects the immune response. And I will talk about that, and that will be the main take-home point of this lecture. So what does SBRT look like? Just to recap a bit from yesterday, we have a target that we outlined very precisely without AI at this point, at least not at MGH. And then we're going to cover this tumor area with high dose. The theme today is hugging, right? It hugs the target volume. And then beyond that, we add a bit of margin, just because it's a moving body that gets covered by a little less than 100% of the dose. Then there's a bit of dose spread around it that's good enough to catch microscopic disease. And then we have what's called the low-dose bath. That's the incoming beams and the outgoing beams. And we've always thought that these do not matter very much, but we are maybe not quite right there, and we'll get into that as to why this low-dose bath actually matters. And then because we also heat the center, which is especially useful for radio-resistant or slightly radio-resistant tumors, because more dose is always better. And historically, the outcomes for SBRT in medically operable patients, have not been bad. Generally, long-term local control is better than 90%. Issues have been mostly in the nodal and distant space where there are recurrences. And then 5-year overall survival is not that great, but it's medically inoperable. So there is at least a 25% chance or so that patients will succumb to other diseases. And generally, as I said, long-term side effects are really rare, a bit of pneumonitis, a bit of chest wall toxicity, and you have to be a little bit careful if you're next to the hilum or the heart, but generally this is a pretty good deal, I'm a little biased, for patients who cannot undergo surgery. And radiation is quite powerful. In contrast to drugs, there's actually no radioresistance. We can kill anything. As long as we get the dose high enough. But we're limited in a way that, if the tumors get too large or if they have biologically unfavorable characteristics, that we cannot get the dose in that we need. And then we need help. We may need help from targeted sensitizers. That's an underdeveloped field in early stage. TKIs are also underdeveloped and not that common. And the sort of the elephant in the room is, can we get help from immunotherapy, or can we, actually help immunotherapy in return? So which way around is it going to be? Dr. Jabbour already covered the trials that are listed here. I will say my slides are more colorful for whatever that's worth. And I'm going to go, I'm just going to touch a little bit here on some of the key aspects of the first 3 trials listed here. And as you heard already, Pacific 4 is not going to read out for quite a while. The iSaber out of MD Anderson was published in The Lancet a couple of years ago, institutional trial with mostly primary disease, but also recurrent disease, 20% of patients treated with SBRT or SBRT-like radiation with nivolumab, only 4 cycles starting at the same time of radiation. And what stands out that these are actually fairly small tumors. Highlighted here, the median tumor size about only 2 centimeters, and as I said, most of them are recurrent. And the results you saw yesterday already in a non-blinded independent central review, that has to be said, with pretty good median follow-up of almost 3 years, there was a significant benefit to adding nivolumab to radiation therapy. And highlighted also yesterday that the benefit was seen specifically in PD-L1 0 patients, which perhaps is a surprise. Perhaps it's a signal that radiation can turn a immune cold tumor into a responsive tumor, but we need more data on that one. When we look at the patterns of failure in these 2 arms, on the right-hand side is the radiation alone, left-hand side with immunotherapy. If you look at the local failures, regional failures, and distant failures in the SBRT alone arm, 13, 10, and 16%, that's perhaps what you would expect. What stands out is that there were no local failures in the immuno arm. And that is a bit of a surprise. You should see some local failures 3 years out, even when you give immunotherapy. So that's to be noted. It was a non-blinded central review. Keynote 867, as you know and heard about yesterday, is not published yet. So we have to sort of withhold a little bit a judgment there. Again, no difference in event-free survival. And you heard that there was an IO benefit in the younger population, less than 65. And you heard also that it was toxic. We don't know why it was toxic or more toxic than the other trials, but certainly 20% grade 3 to 5 toxicity combined with radiation in a medically inoperable population. It's not so great. The SWOG trial was reported at ASCO just a few weeks ago. The design was a little different in that SBRT was not upfront, but there was induction, immunotherapy, and then concurrent and consolidation. And in the trial, the investigators tried to enrich for high-risk features to increase the chances that there will be failures that immunotherapy can impact on. Median tumor size 2.3 centimeters, maybe a little larger than the MD Anderson trial. And in the interim analysis, also no benefit for PFS and OS. And so it closed early with only around 400 patients. It's worth noting here, and Dr. Jabbour already showed this yesterday, that when you look at the breakdown of local progression, regional progression, and distant progression, well, there was more local progression in the immuno arm. And can that really be? It can't really be, right? So there's definitely something in the way here in terms of radiation fibrosis that maybe got enhanced by the immunotherapy and that obscures the effects, especially if there's a blinded review. I'm going to show this on the next slide as well. But what also stands out is that the rate of regional failures and distant failures was quite low. So regional, 10% or so or less, and distant, less than 10%. The follow-up is still short, so there's probably going to be a little higher numbers with longer follow-up. But these patients did better than you would have expected based on the fact that tumors with unfavorable characteristics were actually included in this trial. And so we have to remind ourselves that maybe in a modern lung nodule population, especially coming through screening clinics and whatnot, that the risk of distant failures is not the classical 15 to 20% that we thought. These are cancers that are diagnosed at an earlier stage, and maybe we do a better job staging people as well and get PET scans within 2 months and not 6 months. And distant metastases in all comers may not be that prevalent anymore as they used to be. And so at the end of the day, the reasons for these fairly discrepant clinical and unexpected clinical trial results remains unclear. And we need to find the right patient population to benefit. It is very difficult to see if you have your average patient from nodule clinic where local recurrence rates are less than 10%, regional recurrence rates are less than 10%, and distant recurrence rates are less than 10%, that you can get any measurable impact of immunotherapy in that kind of setting. And on the, does this work here with the pointer? Whoop. No, it does not. But the upper panel you see on the right-hand side, circled in blue, is a subsolid lesion that was treated with SBRT. And then 2 years later, you get this rather solid consolidation in the SBRT field. And if you undergo blinded review at the time, for sure, that will be scored as a local failure because the PET, I will guarantee you, will be positive as well. And in another patient in the lower row, squamous cancer treated with 54 gray and 4 fractions, you eradicate the cancer 5 years later and there's barely a scar left. So there's tremendous heterogeneity in how patients respond to radiation. Now, the responses can be different, but also not all radiation therapy is created equal. So what does that mean? Radiation can induce lymphopenia. Circulating lymphocytes are highly radiosensitive. If you look at the graph in the upper left, you see that doses of less than 1 gray can kill a lot of lymphocytes. That means that the low-dose bath that I showed you initially on one of the slides will kill circulating lymphocytes in large vessels and maybe also in the periphery. And there's a large body of literature suggesting that high-grade radiation-induced lymphopenia correlates with poor survival, recurrence, and metastasis. And there is variation in how sensitive lymphocyte subpopulations are to radiation. This is a good review from my collaborator, Harold Paganetti at MGH. I urge you to take a look at this. It has all the references as well on this topic. And it is actually quite humbling when you read through that. And so then when you look at the low-dose bath, where do you put your radiation? It has to come in somehow. It has to exit somehow. So this is a phase 2 trial, a little bit underpowered, but compared to radiation regimen. One is just, you give the radiation as you would normally do, and then the other one is you try to optimize it. You try to pull the low dose away from your large mediastinal vessels, from the bone marrow and the spine, from the lymph nodes as good as you can. And you see when you do that, you have less lymphopenia. It maybe results in improved survival. Again, underpowered, that's why the p-value is not quite significant. And if you can keep it away from lymph nodes, from priming lymph nodes, that may be associated with better survival as well. And then the $1 million question is, if you had immunotherapy on top of that, what's the interaction? So acute severe lymphopenia may compromise the efficacy of consolidation immunotherapy. That's another analysis from our institution, because now when you think about that radiation will kill lymphocytes, and lymphocytes are very radiosensitive, then it will matter how long your radiation delivery is, right? The longer you have the patient on the table and have the beam on, the more circulating lymphocytes you will catch. And because they are so sensitive, even a little bit dose delivered over a longer period of time will matter. So for example, on the upper left, you see on the y-axis, you see the volume of blood getting more than 0 gray, and on the x-axis is beam on time up to 4 minutes or so. and it goes up for both men and women. In SBRT, you can easily have a patient on the table with beam on for 10 minutes, up to 15 minutes if you do gating, and you're going to catch a lot of lymphocytes, and that's just not good. Same with numbers of fractions. The longer you make your course, the more lymphocytes you're going to catch. So this is generally underappreciated in the field. Now, radiating lymphocytes can be bad, but it can also be good. So certainly radiation can induce expansion of circulating effector T cells. It can increase the diversity of the T cell population, T cell repertoire. And so there are some good benefits as well at sublethal doses. And as you can appreciate, it gets complicated really fast. And it gets also complicated because it's not just, how it affects the circulating lymphocytes, but also how radiation affects the priming of dendritic cells in nearby lymph nodes, how much immunogenic cell death is induced, and what is the time course of all of this. When you start radiation, your immune response will kick in after a few days. But what happens then if you keep continuing to radiate? Now you're going to start killing also some of the cells that you are inducing, and how does that result into synergy or actually, a sub-additive effect? We really do not know how that works, and we don't really know in a population basis, and certainly we don't know on a patient-to-patient basis. So there's a lot of work that still needs to be done. So 2 words of caution I'm going to throw in here. One, you may have noticed I have not said the A word up until this point, the abscopal effect. We don't talk about the abscopal effect anymore because, it is pretty rare. This is a patient from 10 years ago that we treated with palliative radiation to the spine, and okay, the primary shrank a little bit. But those cases are few and far in between, and I don't know. I don't think that is really something that would be striving for. The other word of caution on the right-hand side is that we need to be really careful with preclinical data where the literature is full with studies suggesting abscopal effects, but based on mouse experiments when you use transplant tumors. And those, by and large, are hot tumors. You can get abscopal effects left and right with radiation in those experimental settings, but it does not translate into autochthonous models where a primary tumor arises spontaneously in the desired orthotopic area. So there's a lot of confusion, or has been a lot of confusion in the field. And so we got to be a little cautious there. All right, this was all the rage at ASCO. For those who you were there, I wasn't, but apparently this was really a very impactful trial out of China, randomizing patients based on the time of delivery of immunotherapy, before 3 p.m. or after 3 p.m. And look at this hazard ratio. That is impressive. If this was a drug, it'd be FDA approved by tomorrow. I leave it up to our medical oncology colleagues to figure out how we're going to get the pharmacy to deliver the pembrolizumab by 11 a.m. so we can get done by 3 p.m. But this is amazing. And the literature is full with retrospective studies showing something similar. I have no idea why my slide, the yellow sun turned to blue, but I'm glad that yours is still yellow. Very interesting. So this is a retrospective study just got published in the Green Journal, and they found the same thing. This is stage 3, so it's chemoradiation with durvalumab, but in the lower panel, the same thing. If you give durvalumab earlier, that's better than later, and then conveniently, if you give radiation later in the day, that's better than earlier. And that's striking, right? And it may very well be that the immune system is more active in the early part of the day, where you don't want to have radiation fly around and kill your lymphocytes, and whatever the infusion will do to your immune response, even though the half-life of pembro and all the other agents is really, really long, it might matter. And so there is a lot of literature suggesting that indeed there are circadian changes in the immune response, in the activity of the T cells and tumor-infiltrating lymphocytes. And it so may really matter at which time of the day you give the treatment. Obviously, we're not mice, so in this paper in the Cell that came out recently, the active phase that mice were, had a good immune response was at night, but we are sunny people, so for us it'll be the other way around. But it seems to me that there is clearly something there, and that will have a huge impact on how we practice, and maybe it will explain some of the negative results that we've seen. Another very interesting study from our institution is a surgical study looking at the impact of surgery timing. So if you complete your case by 3 p.m. and you're home by 4, your patients will do so much better than if you go home late. Of course, it's fake, but it would be nice, right? All right, so what makes immune therapy work? So there's a lot of factors. Many of them we can modulate with radiation therapy, where we can help with antigen presentation, we can help with T-cell repertoire, tumor-infiltrating lymphocytes, we can stimulate innate immunity, but we can also kill lymphocytes, and so it's a double-edged sword. Timing of administration of radiation and how we give it, how quickly we give it, and what we do with the low-dose bath is really critical. And I'm out of time, which is good because it's the last slide. So then, what is the ideal clinical trial design? We need to find the right patient population. We need to identify the high-risk patients where there's a local failure, regional failure, distant failure risk that's higher than 10% each. Otherwise, this is not going to work. We need to find the right tumors, PD-L1 high, nothing that sort of negatively predicts an immune response like STK11 or KEAP1 mutations. I'm going to leave to our medical oncologists which drug to use, for how long to give it, maybe shorter is better, how to sequence it, what the duration is. And then you gotta do the radiation just right. And since I'm from MGH, you will forgive me when I hit you on the last slide with protons, but this is an amazing case. The outer colored isodose line is the one gray line, so there is 0 dose to anywhere in the heart or the vessels. And if we can do this with regular radiation, that'd be great too, and that will give us the right balance between lymphocyte sparing and immune stimulating. And with that, thank you for your attention.